Okay, this is Mrs. Halk, and I'm going to go over some specific types of shock. The first podcast was about general information about shock, and now we're going to get into some specifics. You had hypovolemic shock back in the 150s, so this is just a quick review. It is your most common type of shock. You have a decreased intravascular volume, whether it's from dehydration or hemorrhage. Of course, hemorrhage is a more sudden loss, or dehydration is a more gradual loss. Think about your risk factors for dehydration. What age group is at most risk for dehydration? Who it would affect the most. Our medical management for this is to restore that intravascular volume and reverse events leading to the inadequate tissue perfusion. We need to correct the underlying cause as quickly as possible, and we can be doing all three of these at once in reality. Treatment of the underlying cause is really what's going to help, but we treat with fluids, medications, depending on what the cause is. We need to monitor patients to prevent fluid loss, whether it's bleeding or maybe perspiration. And we need to monitor patients receiving aggressive fluid replacement, especially cardiac patients who would be at risk to going into heart failure. So that's all I'm going to say about hypovolemic shock. Cardiogenic shock, you also learned about this in the 241. I'm going to talk about it for a little bit, give you a nice little review. It's when the heart's ability to contract and pump blood is impaired. So the cardiac output is low and oxygen supply is inadequate for the heart and body tissues. So what causes cardiogenic shock? A massive MI. Arrhythmias can cause it. Cardiomyopathies. I'm going to ask you to look those up and know what those are. I'm not going to test you on those, but you need to know what a cardiomyopathy is and that there are different types. And severe hypoxemia and a state of metabolic acidosis. You will see these things in cardiogenic shock, as well as them being causes for it. So we need to limit further damage to the myocardium and try to preserve what healthy tissue we have. So we need to improve cardiac function so we can get better perfusion. We need to take care of the underlying cause. If it's due to ischemia or infarction, we may need an emergent procedure in the cath lab, such as an angioplasty stent to reperfuse, or we may need to take them to the OR, give them open heart surgery and do a cardiac bypass grafting, or we may need to insert an assistive device like an intra-aortic balloon pump or do a combination of therapies. So our medical management is focused on supporting the heart as much as we can, giving oxygen, controlling chest pain. Chest pain means that there is ischemia happening, giving fluids and diuretics carefully, vasoactive meds to support blood pressure, increase contractility, decrease afterload, controlling the heart rate if it's an issue, either with medications or a pacemaker, and using assistive devices to help heart function. Also, we need to be doing serial labs, EKGs, and eventually echocardiogram to evaluate heart function. So when I talk about assistive devices, I'm going to talk about an intra-aortic balloon pump. You can see in this picture, it's a little faint, but you can see it's inserted through the groin, goes up through the femoral artery into the aorta, and this balloon is huge. Right above the renals, these would be your renal arteries. Sits right above your renal arteries all the way up. Let me get my laser pointer, that'll make it a little bit better. These are the renal arteries, so the balloon is from above those all the way up to the aortic arch. So this balloon is the length, almost the whole length of the thorax. Some other assistive devices: ventricular assist device, Impella, or ECMO. There we go. So what I want you to know about an intra-aortic balloon pump, you can see the balloon pump a lot better in this picture, right above the renal artery, all the way to the arch. So what I want you to know about this is that it decreases afterload, or the workload of the heart, and it increases coronary perfusion. So how does it do that? So when the ventricle is getting ready to contract, and you can see it's contracting here, the balloon deflates, almost creating a little bit of a vacuum in the aorta and allowing the ventricle to push blood out into the aorta much easier. When the ventricle is filling, there's always some extra blood left over here, and the balloon inflates, pushing this blood down into the coronary arteries and perfusing the coronary tissue better. So that's the two ways that an intra-aortic balloon pump assists the heart. I want you to remember that. You may see that in a future testing situation. Other devices I will not hold you responsible for, but just so you can see them and know what they are. This is an external VAD. These serve as atrium and ventricles for each side of the heart. The blood comes out, they pump them through and go back into the heart. You're going to see this at bigger institutions. We've done these a few times where I work, but we've gotten less invasive, better devices that we use now, one of which is the Impella. This catheter goes up through the groin. You can see it goes up through the artery, comes in through the aorta, down into the left ventricle, and it has a pump. It pulls blood in, pumps it through, and then ejects it out in the aorta past the valve, and it decreases the workload of the left ventricle. An implanted ventricular assist device is used for those who qualify because their heart is at such low functioning. This is actually implanted in their body and helps circulate their blood. There's a line that comes out through the abdomen to a battery. This is called a drive line, and this is what operates the pump. Our nursing management, we need to prevent organ dysfunction by increasing perfusion, monitor our hemodynamic status, administer fluids and medications, and enhance safety and comfort with our patients. Let's talk about distributive shock. This is when the body's ability to adjust vascular tone is impaired and blood volume is abnormally displaced, meaning that the vascular tone is unable to constrict, and we have massive vasodilation, and the blood volume's displaced out in the extremities and doesn't make it to the core circulation. There's three types of distributive shock: septic, neurogenic, and anaphylactic. It causes what we term as a relative hypovolemia from the displacement of the blood volume, caused by that loss of sympathetic tone, especially in neurogenic shock. And then in septic and anaphylactic shock, it's caused by the release of biochemical mediators from the inflammatory process. So let's talk a little bit about sepsis versus septic shock. You learned about sepsis in 241, life-threatening organ dysfunction caused by infection. And what is the difference between sepsis and septic shock? Well, septic shock is when fluids alone cannot maintain a mean arterial pressure of greater than 65, and you need to have vasopressors to maintain that blood pressure. It also carries with it a greater risk of mortality. And I know the previous slide said 65, this one says 60. For testing purposes, we'll go with 60, but every physician's different. Some like 60, some like 65. It's the most common cause of death in the ICU population, and it's caused by septic shock is caused by a widespread overwhelming infection. You get a activation of the biochemical response from the inflammatory response. What it does is releases these substances that increase capillary permeability, allowing fluid to leak through the capillaries into the tissues, aka third spacing, causes vasodilation, and also activates clotting and fibrinolytic cascades. So you can be bleeding and clotting at the same time. So when we're in our Zoom session, we will go over matching sepsis, severe sepsis and septic shock to the definitions and the examples on this slide. Our medical management, we have to identify and eliminate the cause of infection. We have to provide cardiopulmonary support. We need to be monitoring our urine output to determine our kidney perfusion, our mean arterial pressure to know that we're perfusing the body tissues, and a CVP is necessary not only for fluid and medication administration, but also to monitor that volume coming back to the heart and knowing what our preload is, knowing what our fluid volume status is. An SVO2, how can that be helpful? It's a saturation of venous oxygen. We can draw this off of a CVP, and basically it's going to tell us how the tissues are utilizing the oxygen. If the SVO2 comes back high, we know that for some reason the tissues are not able to utilize the oxygen. If it comes back to us very low, then we know the tissues are eating up the oxygen and we need to be delivering more to the tissues. We're going to use fluid replacement in the form of crystalloids. We need to have antibiotic therapy in place. We collect our cultures first before we start our antibiotic therapy. We're going to start a broad spectrum antibiotic therapy until results of the cultures come back and we can give them more specific antibiotics. We want to measure and follow our lactate levels. You want to measure that lactate level. We want it to be less than 2. Lactate levels mean that when they're elevated, mean we have anaerobic metabolism going on. We're going to give glucocorticoids, also known as steroids. They're thought to help stabilize the capillary membrane and prevent that fluid leak. These patients need nutritional support. We need to maintain a glycemic control because we know that bacteria like sugar to grow, and if we keep the sugars under control, we will help decrease the extent of the infection. We need to control fever to decrease metabolic demands, and vasopressors to maintain our blood pressure. A little bit about SIRS. SIRS is a systemic inflammatory response, and it presents very much like sepsis and is treated very much like sepsis. However, the difference is there's no identifiable source of infection. It is thought to be just an overwhelming inflammatory, immunological, and hormonal response. Like I said, similar to sepsis, but they're not sure what triggers it. However, they will look at SIRS criteria when they're defining if patients are at risk for sepsis. Those of you who go to clinical at Hershey, when you open your patient's chart, you will see right away on the left-hand side whether the patient or not meets SIRS criteria. So SIRS criteria is met when 2 or more of the following are present. They either have a high white count or a low white count, greater than 12,000 or less than 4,000, a heart rate greater than 90, a temperature greater than 38 or less than 36, or a respiratory rate greater than 20 or a CO2 less than 32. So that's septic shock. Neurogenic shock is caused by a spinal cord injury above the level of T6. Can also be caused by any type of nervous system damage and spinal anesthesia. What happens